Hi, and welcome to Johns Hopkins Medicine Online webinar series. Today, we will be speaking about pediatric scrotal and testicular conditions. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The presentation will be the first 45 minutes, and the last 15 minutes will be dedicated to a live Q&A session. Please submit any questions. Please type your question into the Q&A box and click Send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check Send anonymously. We'll do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. For this presentation, we'll be featuring Dr. Ming-Hsien Wang, Associate Professor of Urology and Director of Pediatric Urology Fellowship. And now I will turn it over to Dr. Wang to start the presentation.
All right. Good afternoon, everybody. Chelsea, am I coming through okay?
It's perfect.
Okay, perfect. Okay, so yeah, welcome. Glad we can have this little talk, and I hope this will be helpful. And Chelsea, thank you for the introduction. So let's move to the next slide. Okay. Great. So maybe I thought, we'll start with the case and make this a little more relevant. So basically, this is a boy that I was actually called on a few weeks ago. So previously healthy 7-year-old boy presented to outside ER with 24-hour history of left testicular pain. The boy is otherwise healthy. There's no other voiding issues, no family history of any GU problems. And per outside hospital, the side that he was having pain, which was the left side, there was a little swelling. He's circumcised. There's really nothing else that's too concerning. And they decided to proceed with just a baseline scrotal ultrasound. So when they got the report from the ultrasound, that's when all the phone calls started. So basically on the outside ultrasound, the left testicle appears completely normal. But the right testicle, the opposite side of the pain, show a decreased blood flow, concerning for torsion, detorsion, intermittent torsion. And this is how our story started today. So basically, what I think might be helpful would be going through some of the basic embryology of testicular development, testicular descent. So if we go back to, the fetal stage, even before most women know that they were pregnant, the germ cells are moving from the yolk sac. They migrate into this area called gonadal ridge. And basically the gonads, either girl, boy, they actually look exactly the same at this stage. And this all happened within the first weeks of fetal development. And so then what happens is that if there is presence of Y chromosome, there's a presence of the SRY gene, which is on the shorter arm of the Y chromosome. It leads to the production of the testis determining factor. And with those proper proteins, and assume every step is, kind of carrying through correctly, then the Y chromosome will dictate how these gonads are formed specifically into a testicle. If there's a lack of Y chromosome or if there's a defect in the SRY gene, then you have the development of an ovary. So this all happened during this first few weeks of gestation. And then as the pregnancy moves along, during those first few weeks, the testicles start to develop and start to descend. Basically, the testicle starts out way by the kidneys, and then they travel through to the inguinal region, and that usually happens within the first 10 to 15 weeks of gestation. And then the second stage, usually by the second, third trimester, is when the testicle actually start to go towards the inguinal scrotal region. So if you look at a fetal testis, descent, development, what you're going to see is around the actual testicle, there are multiple layers. And these layers are all from the layers of the abdomen. So if you think about abdominal cavity from the inside, you usually have the peritoneal lining, then you have the transversalis, the internal oblique, and the external oblique. So usually if you have a full-term baby, 80% of them will have the testicles in the scrotum. Or if they don't drop down completely, this usually will happen within the first 3 months, maybe plus minus 6 months. Usually if a testicle still remains in the abdomen or in the groin by 6 months old, assume the baby is a healthy full-term baby, the testicle is probably not going to move any further. Occasionally I will still see some testicle that will come down completely by the time the babies are full at 1 year old, but pretty unlikely at that time. So the reason why we want to treat undescended testicle, there are multiple reasons. So that if this is how I talk to my families. If you think about how a testicle need to grow to develop properly, it really needs to be in a cooler temperature. So if you think about the ambient temperature, it's usually 76, 78. If you think about our, internal temperature, it's more like 97, 98 degrees. So there's a 20-degree temperature difference. So testicles just don't develop well if they stay in the abdomen or inside the body. So definitely, the conversation about having the testicle in the scrotum, place it in the cooler environment will help in terms of development long term. And also with any testicle that doesn't descend correctly, there's always a chance that it could be at a higher risk of testicular torsion. And also there are some long-term studies that shows that intra-abdominal testicles could be at higher risk of developing cancer later on. And there are some studies out there that says having an orchiopexy early on before puberty does this decrease the risk of cancer later on. But usually, if we're doing orchiopexy by the time a boy is a teenager with the onset of puberty, you're really not changing that risk that much at that time. The reason to really do it at that point is really for self exams, and if anything happens, it's much easier to examine a testicle that's in the scrotal sac. So in terms of, what to do clinically when you have a child or a teenager that comes into your ER or your office complaining of testicular pain, the first thing that we kind of want to sort out is this a surgical issue or is this something that we can monitor? So when a resident call me, or when I get a call from an outside physician, the first thing I'm thinking is divide things into two categories. That do I need to call the surgical team to come in the middle of the night, or is this something that we can sit on it for a little bit? So your history and physical at this point is super helpful. So usually you want to ask, like, when did this started? Was it gradual? Was it sudden? What was going on? Was there any trauma? Was the child hit? Is there any other systemic symptoms such as nausea, vomiting? Anytime you have some sort of systemic symptoms, you have to think more towards torsion. Because remember, a testicle starts out in the abdomen. So a lot of the nerves and blood vessels are still in the abdomen. So, for example, if someone is passing a kidney stone, sometimes they'll have referred pain down to the testicle region. And same thing, if there's a twisting of the testicle, a lot of times these children or teenagers will complain that they feel like they want to throw up. So if you hear anything of that sort, you have to start thinking that this could be something that require a surgical management right away. In terms of your exam, usually, if it's something not surgical, not much you're going to notice on the exam. Maybe it's slightly swollen. It's not going to be red. It's not going to be like the cremasteric reflex is also really important to look at. If the testicle is still moving nicely, you're probably not having a active torsion. But if it looks like the testicle is all knotted up towards the groin, hard, firm, then you have to be very, very concerned that the core or the actual blood vessel twisted. And then if you have time, you would get a urine analysis. And usually with testicular torsion, the urine would be completely clean. If there's something else going on, you might see things like blood, you might see white blood cells or something different. And then lastly, if the child is not in horrible acute pain where you're like, this is definitely something surgical, I need to call my urologist. You can always get an ultrasound. When you get an ultrasound with a true testicular torsion, you're not going to have any blood flow. But if it's more like, congested, tons of flow, then you start thinking that, okay, this is not something acutely surgical, that we can wait and sort this out. So let's start with some of the more common reason for testicular pain that's not surgically related. So one of the pretty common things that I see would be this condition, Torus appendix testis, where the way I explain to the parents is that on top of the testicle, there's this little skin tack like thing. It has its own blood supply. So when that twists, it can be pretty painful. It's almost like someone has a little skin tack on their neck. It got caught by a necklace and the whole thing, gets tugged on or pulled on. So the teaching is always like, if you examine these children, assume you can see this faint blue dot sign on the top of the testicle. Sure. A lot of times you're probably not going to see it, but if you ask the child to point where things are painful, they'll usually point to the top of the testicle. So that's one way to kind of sort this out. If you're pretty sure that this is one of those torus appendix testes, the treatment would be rest, elevation, make sure minimize activities for at least a week, try some Motrin, and try some ice pack. And usually this will get better with just being super duper careful for at least 1 week. So this is another relatively common conditions that we see as urologists, and I'm sure you'll see it in your practice, which is nonspecific epididymitis or orchitis. So with this, you get a urine, you get signs of some nonspecific infection. Of course, at this time, you're not going to have the final urine culture, but you'll probably see some white blood cell, nitrite, and it doesn't make any sense because you could have like a little child in front of you versus like a grown man or a teenage boy. A lot of times in these little kids, it's usually not a bacterial infection. A lot of times it's some sort of inflammation because remember, urine is pretty acidic. So if it's an otherwise healthy kid, things I will be looking for is I will ask them, how's your urinary stream? A lot of times kids don't know, so then maybe ask the parents, because what you want to rule out would be things like obstruction. Common things would be meatal stenosis. So usually that's right at the tip of the meatus. If you take a look, rather than that nice slit like where when they urinate it opens, it looks more like a pinpoint. So which means that if you ask the parents to look to see how they're urinating the next few days, it will look like someone put their finger over the hose in your backyard. It's going to spray all over the place. If that's the case, then you kind of know that this is probably the problem. So the reason why we want to check for these things is that if there's some sort of obstruction with a urethral opening or something that's a little bit deeper towards the bladder, urine will efflux back to the epididymal region. And that can definitely cause a lot of inflammation, infection, and also testicular pain. So always check for stuff like this. And again, going back to your good history and physical, if they ever had any urethral surgery like hypospadias, those are the things that will kind of help you to figure out why is a healthy child diagnosed with epididymitis or orchitis. Okay, so those would be the two things that's pretty common, torus appendix testis and also these non-specific inflammatory changes to the testicle. So now let's move on to, something more surgical, more acute that we really need to act on quickly. So acute testicular torsion, this is the bad one. Basically, testicle is an end organ. So once you lose it, you can't really get another one. So usually with acute torsion, this happens more common around the time of puberty because the testicles are getting bigger, heavier, but the spermatic core and vessel hasn't really quite caught up with the testicle. So it's more prone to twisting. Occasionally, it will twist a little bit and untwist. And if you ask these young boys, they'll probably give you a history like, oh, yeah, this happened a few months ago, and then it happened again. And now it's more like every other week. Or the parents might say, well, we went to the ER, we went to urgent care, they did an ultrasound, everything looked good. But they're still having this problem at home. So if you hear history like this over and over again, it's probably time to refer them to a urologist. Or if they show up with the testicles completely twisted, when you do your exam, you'll definitely see it's super tender. The testicle is to the inguinal region. And basically, that's something that probably needs to go into the operating room. And again, if they're telling you they feel like they want to vomit, that's also a pretty accurate sign that this is a acute surgical problem. Okay. So in terms of, how often are we able to save these testicles? If we can get them into the operating room less than 4 hours, hopefully we're able to untwist, get the blood supply back into the testicles. But that doesn't, happen consistently because we definitely have kids or teenagers coming from pretty far. So then at that point, the hope is it's not twisted 720 degrees. It's more like 360. So there's still a chance that we can get things twisted and bring blood back into the testicle. I definitely seen this before, which is great because everybody's happy. And then another thing that, as a community physician, you can try to do, assume that kid will let you touch them, would be you can try to physically detorse a twisted testicle. I will probably give these young men a little pain meds, and you want to do it like basically like you're opening a book. So if you're standing between their legs, you want to do open book, and that's usually will help and the pain should go away right away. But you should probably still send this kid to like a bigger hospital where they can schedule the testicular fixation so this doesn't happen again. Because what you don't want is send these type of kids home and then a twist again at home, but this time you don't have enough time to get them to the operating room. And then, so, that's the main thing about these testicular torsion in our teenage population. So the next thing that we see occasionally, these are usually NICU or newborn nursery phone calls where they have a newborn baby. When they did the exam, it looks like the scrotal area is super swollen, super hard. They do an ultrasound and there's no flow to the testicle. So this is a very special occasion. It doesn't happen that often. So with these neonatal testicular torsion, this happened before the baby is born. Usually what happened was as the testicle is coming down through the groin into the scrotum, somehow things got twisted. And these testicles are usually not salvageable because we don't know how long ago this happened. And the goal is really preserve that contralateral testicle to make sure that that other testicle is doing okay. And depends on what practice where you were trained. I was trained at UCSF in San Francisco. So when I was training out there, the thought was we still want to bring a baby like this into the operating room, assume that we have pediatric anesthesiologists, everybody feel, pretty comfortable in putting a newborn baby under the anesthesia in order to tack down the healthy testicle to prevent another torsion, which can happen during that first few weeks of life, and then probably remove the torus testicle. But again, this a lot of it depends on where the baby is born, what's reasonable. Do you have pediatric anesthesia available? Do you have an ICU available? So these babies could be admitted at least 24 hours for observation. All right, so let's go back to our initial case of that 7-year-old healthy boy who presented to the outside ER with 24 hours of left testicular pain without history of trauma, really no voiding problems. On exam, slightly swollen, but nothing really concerning. But that ultrasound report is super concerning because the left testicle, the side of the pain, looks great, nothing too unusual. But the one on the right is the one that's read as high riding, no good blood flow, and possible intermittent torsion or partial torsion. So at this point, they call the urologist on call at the outside facility. It happened to be one of our adult urologists. He basically called me on a Sunday and we talked about this because something just doesn't make any sense. And they were ready to even call the OR team in. So then when I got this phone call, I was like, okay, well, it doesn't make any sense. The side of the pain is not the side read as possible torsion. So why don't we transfer the kid to downtown Hopkins, where we have a dedicated pediatric radiologist on call, including the technician. Plus, we have the machine for a little kid. So we got a repeat ultrasound down at Hopkins. And I looked at it, the pediatric radiologist looked at it. There was actually good blood flow to both testicles, which is super reassuring. And what they saw was actually a torus left appendix testis. So the plan was cancel the OR. Nobody needs to come in on a Sunday. And we can just watch this child with Motrin ice and elevation He did great. He saw me again 2 days after Sunday. Everything was pretty much perfect. So a good story, a good ending to the 7-year-old boy. All right. So that's transition to something else that could be in the scrotal region that's not as acute as a testicular torsion. So again, scrotal swelling, hydrocele hernia is another very common condition that you'll probably see in your practice. I definitely see a lot of this, both from inpatient consults and outpatient consults, office visits. So I think again, it's helpful to think about our anatomy and does this how a testicle go from the abdomen to the groin down to the scrotal sac. So this is the picture I often share with the families when they come in. So it kind of makes sense why their child's scrotum looks so big and why does it change in size. So if we think about a testicle, it has to go through the inguinal canal and then that canal closes and life is good. Occasionally, that canal in the groin can pop open, and some of the fluid from the abdomen, the peritoneal fluid, can come in and out. This is where you get the on and off swelling. Usually, towards the end of the day, it'll look a little bigger. When they are waking up first thing in the morning, you're probably not going to see anything. So in that case, it's probably this communicating hydrocele. But if it's always big, pretty consistent, like a water balloon, you probably have something that's not communicating. So it would be that picture in the middle. So, usually in little children, and not your teenagers who go weightlifting and then something popped open, like a hernia with bowel and fat in the scrotum. So, with little kids, or if they had a history of undescended testicle, where the testicle was stuck in the groin, they can have this indirect communicating hydrocele, or if there's some fat stuck in the groin, then we call it indirect inguinal hernia. So the pathology is all the same. It's because you have that communication. And usually, if there's an inguinal testicle, there's a high likelihood you also have a communicating hydrocele associated with it. And the pathology is this patent process vaginalis thing, which basically is your peritoneal opening. So it's the same exact thing, except it has a different term. Once you're talking about the groin, once you're talking about the testicle. And again, this is very common in our pediatric population. So clinically, like I was saying, it can be on and off. That's what the parents are seeing at home. So what I normally tell the parents is that, if they're in my clinic in the morning, sometimes I don't see anything. They don't see anything. I will have families go home and maybe take some pictures of what things look like in the morning versus the afternoon. And then, of course, they can always load it up into the MyChart nowadays, since we have Epic, as a way to document, as a way to communicate with me. And again, this happens quite often in your babies who are premature, just because that testicle hasn't dropped down completely, so that inguinal opening is still open. And once the babies are full term, usually, this and the testicle drops, this will close off on its own. And basically, what I normally want the parents to do is really try your best to avoid any Valsalva. So for the kids who are potty training, age 2 to 3, make sure they're not holding, don't hold poop, don't hold urine, because if they're holding, they're straining and pushing. It can definitely keep this communication open. And with some of the preterm babies, either they're in the ICU getting positive oxygen, or they could be very colicky because their GI system is still developing. Not much you can do other than being supportive. Maybe a tighter diaper to put a little counter pressure so it doesn't get massive. It's similar to, I guess, some of the babies have umbilical hernia. The hope is that with, as the baby gets a little bit bigger, healthier, this thing will go away. Occasionally, it doesn't go away, or a kid could be straining so hard that they push part of the intestine into the sac and the intestine gets stuck. If that happens, the child will be vomiting, the whole area would be super red. That's when they need to go to the ER. And if we can physically reduce it, great. If we can't reduce that bowel into the abdomen, then we might have to go to the operating room. Okay, so again, younger kids, these things tend to heal on its own with just good supportive care. Like things I have seen, kids with asthma, poorly controlled or recurrent respiratory infection, coughing, pneumonia, all that stuff is not very, helpful. So we want to try to treat all these issues even before surgery, because if their asthma, pneumonia, respiratory infection hasn't been well managed, no matter what kind of suture that we use, they can actually pop another hernia on the other side. So just some of the things we really try to do to get these kids healthier. And for me, I see a lot of kids who tend to hold their poop. So we talked about, how important it is to make sure you're pooping every day, fruits, veggies, and good potty routine. Occasionally, I also have to worry about social concerns. Who is going to take care of this kid? Just because half of my practice is in Baltimore. And if there's a lot of social concerns where the kid is not getting the care they need, a hernia can also recur. So, a lot of things to consider. It's not as easy as, a few stitches to close the hernia sac. We definitely don't want these things to keep on coming back. Okay, so let's talk about the non-communicating hydrocele. So this is usually more your teenagers or our adult patients. I do see some adult patients in my practice. So basically, this is that fluid that's kind of so around the testicle, there are multiple layers, and those layers will make some fluid so the testicle can move easily and not getting stuck. The body is smart and knows to reabsorb the extra fluid, but sometimes that balance is not quite there. So then the water balloon gets bigger and bigger and bigger. If it's not too terrible or uncomfortable, you can monitor these things. But if it's bothering like a teenager because now they feel awkward or they have trouble putting their underwear on or anything like that, then we can, discuss the pros and cons of having the surgery to remove it. If we do need to remove these things, it's usually an outpatient procedure. The hardest part with the teenager is all the sports. So we try to schedule on around the time where they don't have too many sports, because they really can't do football, soccer, or any contact sports afterwards for 30 days, or they can bleed into the scrotal region. Okay. So this is something else that you might see during your wild child visits or sports physical, which is these things called epididymal cysts or spermatoceles. It's basically exactly the same thing. They look like a tiny little cyst. Sometimes they can be a little bigger, that these boys can feel themselves, or you might feel it during your physical exam. These are not cancer. because that's usually the first thing the boys are worrying about or the parents are worrying about. It just a cyst. Like most people have a cyst. If you scan us from head to toe, these cysts usually don't get bigger, they don't pop, they don't become cancer. So that's what I tell these families so they're less concerned and they feel really smooth. They're not like irregular. So a testicular tumor will feel really hard. They grow really fast and they will feel definitely irregular. So, you know, a lot of times parents are really worried. We'll get a baseline ultrasound just to document the cyst. If they stay small, it's not bothersome, we just leave it. But if it does get really big, and I have seen pretty big ones that these boys have, just they're so self-conscious. They don't want to wear any pants. I might be a little tight. Then we have surgery to remove it. And the post-op recovery will be very similar to that removal of the hydrocele. All right. So varicocele. Basically, when I see these families, what I tell them is think about varicose veins. And once they hear that, it kind of makes sense. So this happens around teenage years because, again, the testicle is growing so fast. So there's a lot of blood going down to this region, and testicles are dependent gravity. So, and the veins sometimes can get big, just like, what I said to the families. A lot of people in the medical profession, we're always on our feet, legs get swollen, veins get big, and we wear supportive tights to try to hope that these veins don't get too big or too ugly that you wind up needing surgery. So this can happen in teenage boys too, because they're doing their self-exam, they find these funny looking blue things and they think it might be cancer. So then they get really nervous and we try to, like, at least in my practice, I try to calm them down that nothing horrible is happening, but let's talk a little bit about your blood vessels. So these, again, is just these dilated veins. The reason why it's so obvious down in the scrotal region is because if you think about it, the lining of the testicle, basically you have a testicle, maybe a little bit of fatty tissue, usually not a lot, and then you have your skin. So anything that bulges out, it's going to be very easy to see. And again, this tend to happen a lot more during those teenage years because everything is growing, tons of blood going down into that area. And most commonly, they happen on the left side. It's because the way our veins travel from the testicle back into your IVC. So again, the diagnosis usually made on physical exam, and usually by the time the kids come to me, they already had an ultrasound that shows that these are just big veins. It's not a tumor, which is reassuring. And we do have a grading system in urology. We grade them from 0 to 3. I don't think anybody cares about 0 because these patients can't see it. And it only happens during the ultrasound when the technician is asking the patient to Valsalva. Other than that, nothing concerning. Usually, grade 3 are the ones where when I examine these boys, I ask them to stand up and you'll see it right away. You'll see those big dilated veins. And then of course, that's the grade 3, and that's usually what's bothering them. And so, when we have these discussions, this is like the stuff I look at. I also you want to examine the testicle, make sure there's nothing else where the testicles are asymmetric or you feel anything concerning. So things that could be concerning is if they come in complaining of these veins on the right side, because usually it should not be on the right side. It should be on the left side. If there's any like these dilated veins on the right side, you have to think, is there something in the abdomen that could be pushing on the veins that could cause these veins by the testicle to swell up like this? Um, so yeah, so this is more like in your slightly older population, like men in their 30s, where you start thinking about, or 20s nowadays, start to think about things like testicular tumor and lymph nodes that could put pressure on these veins on the right. Okay, so surgery or no surgery. So every family is different. So things they usually are worrying about is this a tumor that they need to worry about? No, so we can rule that out. Are you having any pain? With these varicocele related pain, usually it's not your sharp pain. It'll feel more like a dull, achy pain more towards the end of the day just because of gravity. Just like, your legs start to hurt if you have those varicose veins on your legs. It's more that dull pain. It's not the sharp stabbing pain. And then the second question that usually come up is that, is my son going to have fertility issue, sexual function issue? Usually not, unless, if you palpate the testicles, the side that has the varicoceles, the testicle feels smaller or softer, then that's concerning. Okay. So, yeah, so for me, when talk to these families about the pros and cons and risks and benefits of having these varicoceles treated, would be if there's definitely a difference in the testicular size, we probably want to do something so you don't have all that, vein, warm blood right next to the testicle, because we know the testicle does not like to be in a warmer temperature. So that's one thing. If they just absolutely hate the way it looks, it really bothers them, then we talked about surgery. Or the parents are so concerned with fertility issues, or if they already have a fertility issues in the family, then we can, have a good conversation about, like, do they want to go through surgery? Do they want not to do surgery? Occasionally, these varicose veins can come back. So there's a lot of pros and cons and risks and benefits. And at least right now in our literature, the gold standard is really having this microscopic subinguinal varicocelectomy. What that means is that it would still be an outpatient surgery, and the recovery would be like all the other scrotal groin surgery of 30 days of no strain, strenuous activity like football, soccer, contact sports. And it's actually, the scar is pretty small. It's maybe about 1 centimeter in the low inguinal region. So by the time everything heals, nobody would know that this boy has had any surgery. And the success rate is great. It's done under the microscope. So it's actually really nice. So if we're able to catch these things early on, get it treated right away, there's a very good possibility that testicle will catch up with the other side, because these young boys are still growing, things are still developing. And even, some of the studies in men with fertility issues, the semen quality does improve. So that's great. And in terms of that dull, achy pain, it definitely gets better. So yeah, so overall, it depends on what the family wants, but surgery, if they're willing to put in that 30 days of recovery, doing nothing, it's actually we have really good success rate. So I think that's all I have for now. I'm happy to take any questions.
So Does the first question, does delaying the procedure for acute torsion, does that lead to more complications? And if so, how serious are the complications?
So the teaching for us is always you want to get the kid into the operating room within 4 hours, but we know that's not really realistic, right? Because it depends on the degree of torsion, it depends on how long the testicle hasn't had adequate blood supply, but we're always aiming to get these kids into the operating room within 4 hours as soon as they walk in the door to the ER. If a child says, or the parent says, there's acute testicular pain, that kind of activates everything. We call it level one. But so that say, this was missed because this young man or teenager didn't want to say anything, which we see that a lot too because they're self-conscious. And then they come in later because now their testicle seems smaller and smaller. Usually that's what happens. If there's a torsion of lack of blood supply that wasn't caught, the testicle will get smaller. And if it's an intermittent torsion and it happens over and over again, the testicle can also just not develop correctly. So the contralateral one will grow pretty big, while the one that's having pain or the intermittent pain will get smaller and smaller. Does that kind of helpful? Okay. So I see what is your counseling to young men about surveillance or screening for testicular cancer? Yeah. So if I see them, before they became a teenager, I have some patients I follow over the years for other things. So we do talk a little bit about, just like girls, I kind of talk to them about sexual health and how to protect themselves once they're have boyfriends and other things. Same thing for the boys. I always do a good exam. I show them how to do a testicular exam, and I'll usually have parents in the room that can be behind the curtains. They can turn around so that the child or the boy feels like there's some privacy, but everybody hears it. That you should be, palpating your testicles to make sure there's no weird masses, just like women have to do breast exam. A lot of times these boys are already doing that. They're just not talking about it. So yeah, so that's how I wind up getting a lot of these young people coming in with spermatic cysts or weird veins. It's actually because they're already doing it at home and they find something or they see something that's concerning. Okay, 3, if you have a newborn with a large hydrocele and you can't tell if there's a associated hernia, do you recommend just waiting until the hydrocele resolves and then obtain an ultrasound? If you are concerned with the hydrocele, if you are still concerned after the hydrocele is improved or resolved. Okay, so I have seen these giant, massive scrotal swelling where I can't tell, if there's a healthy testicle in there, what is going on. So with these giant hydrocele, I think it's helpful to get an ultrasound because these things happen in preterm babies or babies. I usually will have like a dedicated pediatric radiology tech doing these ultrasounds because baby testicles are pretty small. And if if you do these ultrasounds on like, some of the outside institution where they don't have these ultrasound machine dedicated to pediatric population, they might read there's no flow to the testicle because that hydrocele is compressing on the testicle. So yeah, so you probably want a dedicated pediatric, place to do your ultrasounds. So that's one thing. And ultrasound will also rule out things like, is there a piece of bowel that's incarcerated? So that will be helpful. And yeah, so, and then usually if I can keep a kid nice and healthy, the parents get a lot of education about trying to avoid Valsalva, a slightly tighter, diaper to give it a little counter traction. These massive giant hydroceles will get better and better. And if we do need to go and do something, Usually I'll wait until they're about at least 10 to 12 months old. That hydrocele or hernia repair will go so much easier. Number four, how often are additional surgeries needed to hernia? Yeah, so this is the part where that pre-op counseling and preparation is so important, and also the social situation, because if the parents don't understand that if you don't take care of this, if you're still straining and pushing, you can pop those stitches open. So hopefully, we always say to the families, like, assume everything goes perfectly, surgically wise, and the kid is healthy, life is good going into it. The success rate should be 95%, where the hernia sac will be closed, there's no injury to anything else around it, and this should not come back again. But if they think that, okay, we can go back and doing everything we were doing before, and they have a bad pneumonia or they, contact sports right away, these things can pop open. And then there's always that 5% where you actually have to go back and fix the hernia. Just a comment. I saw an 11-year-old with left side scrotal swelling. Right scrotum was not swollen, was transluminating, and the left swollen one was not transluminating. Okay. Um, okay, so the right side, you were able to hold a light and you could see it was just liquid, but the left side was not transluminating. So this is a kid, probably you want to just get an ultrasound to document that there is no bowel, there is no fat that's stuck on into the left scrotum. That would be the easiest because you're not always going to be able to tell. It's like it's that blue dot sign too. It depends on the color, the skin color, or yeah. So I would just get an ultrasound on this boy. Last question. Do you offer robotic surgery for hernias and other conditions? Okay. So I don't, and as far as Hopkins children goes, I know our pediatric surgeons are trying to use the robot for these hernia repairs. But they're still in the learning process, so I can't say it's a consistent tools that we use. But I know our pediatric surgeons, there's like five of them right now. So some of the slightly who train in the era before the laparoscopy robot tend to do these hernias open. And that's how I was trained. I was trained at Mayo Clinic back in 1999. So everything was open. We really didn't have laparoscopy or anything like that. So here, with the pediatric surgeons, the slightly older surgeons like me, we tend to do open. The ones kind of slightly after us, they do laparoscopic, but they do have newer surgeons coming in who want to utilize the robot for these hernia repairs, but not consistently.
Thank you, Dr. Wong. That was very informative.
Okay,
Um,
good.
So, thank you everyone for attending today's webinar. If you have any questions, you can email us at hopkinsseminars at jhmi.edu. To request an appointment, you can call 410-955-6108. And a follow-up survey will be sent to you as well. And again, thank you for joining today's webinar.
Yeah, take a screenshot. All right. Well, thanks everybody. Have a wonderful weekend. Thank you, Chelsea.